Support team, kindly give a countdown.
Yes,
Can we
ma'am. We
start?
can start now.
Okay. So, good evening to all. For today, Dr. Abha has handed over the mantle to a very deserving and bright speaker, Dr. Tejashri Shrotri. Dr. Tejashri will be talking on thin endometrium, a scenario all clinicians regularly struggle with. So, to throw more light on this and enlighten us, we have Dr. Tejashri.
Hello, everyone. So, good evening. Thank you for joining in today when Dr. Abha could not, because she's traveling to her daughter's place. And I'm sure if she finds time, she would be happily be joining us midway also. Uh, I have worked with Dr. Abha for a few years. I know a lot of us audience have worked with her, and her enthusiasm is something which we always try to replicate, but we can't. That is something very unique to Dr. Abha. But I would like to share a few things which I learned from her and also from the experience that I gathered while practicing. So, coming to the endometrium part today, we all know that implantation requires three important things. The first is receptive endometrium, a competent good grade embryo, and a orchestrated synchronized crosstalk between these two. However, today we are going to talk about endometrium. This is a good proliferative endometrium that you can see here under the influence of estrogen in the proliferative phase. It undergoes multiplication, growth, and then after ovulation, we all know that progesterone comes in, wherein the secretory changes set in and it becomes receptive when the window of implantation opens up about 19 to 21 days of the cycle. And you all know that endometrium is a resilient, highly dynamic tissue. It has the ability to undergo rapid regeneration, which is unique to this tissue. However, very, very long back, Robert Edwards had once said that endometrium is the last barrier to the progress of ART. And how true was this? Because today we know that embryo implantation remains the rate limiting step in achieving success in IVF. Because in current practice now, with the advanced lab standards and the quality of culture media that we have, robust cryopreservation techniques, we get high quality, even euploid embryos with the PGTA technique. And what now remains is the impaired endometrial receptivity, which contributes to about 2/3 of embryo implantation failures. And numerous reports have shown that thin endometrium is associated with low implantation rate. So a part of this endometrial receptivity might be because the endometrium has not grown enough. So endometrial thickness on the ultrasound remains the most commonly used predictor for endometrial receptivity for live birth rate in ART programs. Now, looking at the endometrium picture here, we all know how we measure it. So from one echogenic part to the other across the endometrial thickness, in the longitudinal section, we measure the endometrium. Why is endometrial thickness on ultrasound considered the best predictor? Is because it is easily measurable. There is an excellent intra and inter-observer reliability. And of course, there is a significant correlation with the serum estradiol levels. So that is the reason why we rely on the ultrasound finding of the endometrium to predict that whether it is going to be accepting the embryo or will there be a challenge. Now, people also try to study other parameters like endometrial volume, Doppler study of the uterine vessels, Doppler flow of the spiral arteries, endometrial and subendometrial vascularity. Endometrial volume of about 3 to 5 ml is something which was studied and found that the correlation for the Doppler studies of spiral arteries and the subendometrial vascularity. In one time, we used to do the subendometrial vascularity and see the zones of flow, but now the role of this subendometrial vascularity is controversial and most studies are required, and even we have stopped doing the flow studies nowadays, and we have found that the results are not significantly different even when we are not looking at the flows. So we now look only at the thickness of the endometrium. So why are we so concerned? Why are we so concerned about the endometrial thickness? We all know that the decreased endometrial thickness will have a decreased receptivity and therefore decreased likelihood of pregnancy. Though this may not be linear, that does not mean that if the endometrial thickness is going thinner and the rates of pregnancy might be correlating to that, but it certainly has a good negative predictive value that if it is below certain cutoffs, pregnancy rates would go down. But there's also another thing. It's not just the pregnancy rates. Even when the patient gets pregnant, there is a higher chance of miscarriages, ectopic pregnancies, lower birth weight babies, preterm deliveries, and most importantly, placental abnormalities. Why is this? Because we all know that the functional layer is something which gets shed off. Basal layer is the one which grows under the influence of estrogen. And when the functional layer is lesser, that means it is thinner than normal, the embryo comes very close to the spiral arteries. And therefore, the oxygenation or the oxidative stress towards the embryo increases. And all these implantation problems happen because of that. So that's one theory. Like we all know, the embryo likes to grow in a low oxygen state. And that's why even in the lab conditions, they are kept at about 2 to 5% of oxygen saturation. So here, if the exposure of oxygen of a normal blood that is going into spiral arteries is at a higher level, it might be leading to all these issues. Now, what is the incidence and how do we find out the incidence, and is it that significant that we should be taking a note of it? For calculating the incidence, we need to know what the cutoff is. Now, various people have taken various cutoffs from 6 mm to 8 mm to call it a endometrium which is thin. So like if it is less than 7, it's called thin, or less than 6. But there was a study which was conducted in 2014 August, and this is where they used a cutoff of 7 mm and reported an incidence of 2.4% with a cutoff of 7 mm. Now, where did this 7 mm come from? That's we'll come to that. But before that, mind you that this 2.4% of incidence that is cited in this largest study, wherein they studied about 40,000 cycles, came from only those which were reported. There might be more cases which got cancelled because of the thin endometrium, and those were not taken into consideration. So the incidence could be higher if we take a cutoff and include all the cycles that were cancelled. Now, this is another study in which again 40,000 embryos were studied in fresh and frozen donor cycles. So the embryo part was negated. The embryo influence was negated. The only endometrial thickness part was important in this study and considered millimeter wise. So what they did was below 8 mm, for every mm, they found out what was the pregnancy, clinical pregnancy rate, loss rate, and live birth rate. So this is for the fresh, wherein they did it for below 8 mm. They found that the incidence is, starts decreasing, and the clinical pregnancy starts decreasing after 8 mm. Rather 7 mm, sorry, for fresh cycles. But the thing to note in this is that even below 5 mm, there is 18% live birth rate, which is quite significant, which is something we should be noting, which is not like very less, which is, quite a significant live birth rate. Similarly, for frozen cycles, if you see, the pregnancy rates start falling after 7 mm. Again, in these cycles, even below the 5 mm cutoff, there were about 21% live birth rate out of all the patients that they found to be in this category. So this is something we should be noting, because clinical pregnancy rate and live birth rates decrease with each millimeter of endometrial thickness below 8 mm in fresh, below 7 mm in frozen cycle. This was the inference drawn from the study. Nevertheless, viable pregnancies remain reasonably acceptable, even with the endometrial thickness between 4 to 6. Having said that, none of these studies have given us a cutoff where we should be cancelling the cycle. So now how do we know? How do we know that, the endometrium is normal? Should we go ahead or should we cancel the cycle? For this, we need to understand the causes of thin endometrium. The causes are various. So it can be hormonal, which is premature ovarian failure, prolactin disorders, or hyperandrogenism, basically hypoestrogenic state where the estrogen levels are lower, and that's why the endometrium is thin. And then, of course, that is reversible. We can give estrogen and build up the endometrium. There could be inflammatory causes like tuberculosis, non-tuberculous endometritis, change in the normal microbiome, or chronic endometritis, which is causing thin endometrium. This might be partially reversible or might be irreversible, like tuberculous endometritis, which causes adhesions. Asherman's may not be reversible. Iatrogenic causes, DNC, previous surgery, intrauterine surgery, Asherman's itself, pelvic radiation, septic abortion, and not to forget ovulation induction, like cyphene. If we give, we all know that it has an impact on the endometrium and may be a cause of thin endometrium. So leaving that aside, rest of the causes in this category would be irreversible. Idiopathic is something which may not be having any pathological cause of thin endometrium, and that could be maybe a constitutional thing that inherently the patient has endometrium which is less than 7 mm. So idiopathic is where we really can't find the cause. But here I also want to bring to note this study, which reported a higher incidence of thin endometrium below 9 mm, even in natural cycles, in patients of 41 to 45 years to the tune of 25%, which is quite high. So age probably has an impact on the thickness of the endometrium. We need to look into this because we always thought that the endometrium is non-senescent and it does not age. And if we replace the egg, we could get good number of pregnancies, rather equal number of pregnancies, even like younger women, because egg is the reason for not being able to conceive. So if we replace the egg, the pregnancy rates would be matching younger women. But again, this endometrial aging is something which is coming up, and that could be one reason why we might be having thin endometrium. Now, again, we need to find out which are the patients. So this was a study which was conducted in a huge number of cases, but here they found 16 cases of adhesions, like intrauterine adhesions, out of which 3 had less than 6 mm. Even after adhesiolysis, all these 3 patients never got pregnant. Remaining 13 out of the 16 had endometrium between 6 to 8.2, in which 1 clinical pregnancy occurred but landed in missed abortion. So here we could infer that patients diagnosed with intrauterine adhesions had lower pregnancy rate compared to those diagnosed with other intrauterine problems like leiomyomas or polyps. All intrauterine adhesions presented in cycles with endometrium below 8.2. So none of them ever crossed 8.2. The major inference of this study that I want you to take note of is that in most of the cases, the causative agent remained unknown. So only 16 cases they found of adhesions, few of myomas, polyps and all. But many of the cases, they really could not find any cause. So it is possible that only some of the cases with poor endometrial growth would be related to impaired implantation. So there may only a few causes of thin endometrium. In thin endometrium cases, may be a normal finding, with no adverse effects on the implantation rate. And determination of the factor accompanying thin endometrium is something we have to find out so that we can identify this patient and have a tailored medical treatment to build adequate endometrium. Again, in October 24, this was a study wherein they did a single embryo transfer and in thin endometrium patients, and they inferred, if you look at the last line, it says that patient with thin endometrial lining, those who were constitutionally thin and had a history of endometrial implantation had similar outcomes. The lowest were seen in Asherman syndrome. So now somewhere we are getting this thing that adhesions, Asherman has the poorest prognosis. All these studies are inferring a similar tune of things. Similarly, again, one more study. So we have talked about the thickness, the Doppler flows, the volume of the uterus, but what we also have to see is the endometrial pattern, because that is something which might be predictive of pregnancy even with a thin endometrium. If we have a good triple line pattern, that could be predictive of a better outcome. So this is a study which got published in September 2024, wherein they saw what different patterns were associated with the pregnancy, different pregnancy rates. So leaf pattern where central echogenic line was present, continuous, unbroken along the full length, partial where it was a discontinuous line, and non-leaf pattern where central echogenic line could not be clearly distinguished, the third on the left. So endometrial pattern was not associated with differences in endometrial thickness. Even with a thin endometrium, you could have any of these patterns. If it has a good, leaf pattern, that's what they're naming it, then you might have a better prognosis. So across all cycles, non-leaf was more common than leaf pattern with the history of uterine evacuation. If there was a history that uterus has undergone an evacuation of pregnancy, then it would have more commonly the non-leaf pattern, and that leads to reduced live births and increased miscarriage rate. We all know that the physical trauma caused by intrauterine curettage might cause fibrotic changes and obstruct the uterine cavity. So non-leaf patterns may have arisen out of endometrial fibrosis and would have affected the pregnancy rate. So these are the patients whom we need to look into. With thin endometrium with a non-triple line pattern is something we need to look into. Now, where all do we come across thin AT? We might come across in IUI cycles, fresh IVF cycles, in FET cycles. So what do we do in IUI cycles? May 2017, endometrial thickness in women undergoing IUI, how thick is too thin, was a systemic review and meta-analysis. I'm just putting up the gist of this, but the first line is the most important, that they could not find any evidence for association between endometrial thickness and pregnancy rates, and therefore cancelling IUI cycles because of thin endometrium may negatively affect clinical care. That means patient already has a lesser success rate in IUI cycles compared to IVF, and if we end up cancelling those cycles, we are putting that chance to zero. So they are suggesting that don't cancel the IUI cycles, you go ahead with that, and some few patients might get pregnant even with thin endometrium if you do a good IUI. Here, CC had a marginally thinner endometrium compared to gonadotropin. All of us know that there was no difference between CC letrozole. CC plus gonadotropin had slightly thinner endometrium than letrozole, because once you add CC, it has a effect on the endometrium. Letrozole alone was slightly thinner than gonadotropin. So the best was gonadotropin alone, letrozole followed by CC plus gonadotropin followed by clomiphene citrate. So that was we all understand the pathophysiology of clomiphene citrate. So we know that if the endometrium is thin because of that, then we are moving to gonadotropin cycles in those patients. Now, if we encounter a thin endometrium in a fresh cycle, these are the proposed treatments that various studies have tried to study whether it really affects the pregnancy rates. So changing the stimulation protocol, addition of luteal phase estradiol, of adjuvants, which increase the blood flow to the endometrium, and cryopreservation of all embryos. However, Canadian Fertility Androgen Society has made a guideline after going through all the studies and has very clearly given us this, that there is insufficient evidence to recommend any change in the stimulation protocol. So once we have the endometrium ready for trigger or transfer, we can't really change anything much in that. In ovarian stimulation cycles, there is insufficient evidence to recommend any adjuvants. In fresh embryo transfer cycle, we need to counsel the patient that if it is below 8, they might have lesser pregnancy rates and live birth rates. In fresh cycle with thin endometrium, we can offer them elective cryopreservation so that we get time to evaluate why the endometrium is thin, what can we do about it. Sometimes in FET with certain protocols, we might get better thickness, so we can offer them elective cryopreservation. Of course, luteal estradiol again has not found any role. So only intervention we can offer is to freeze all the embryos and then counsel them that we will go ahead with FET, and probably that will lead to a better pregnancy rates. Now, what do we do once we find the endometrium is thin? Most of the cases, history of the patient gives us a lot of information. So we can't miss out on this. A lot of the times in OPDs, we see that we ask the patient, and then when nobody is there, she tells us that I had unwanted pregnancy when I was unmarried and had undergone a DNC, or she gives us a history of exposure of tuberculosis to somebody who had it in the family. So the history is very important. We should not be missing out, especially if we find it for the first time during stimulation. Secondly, first step would be 3D ultrasound and or hysteroscopy. If the 3D ultrasound is showing us a irregular endometrium, of course, we'll go in for hysteroscopy, but even otherwise, as a first step, we can offer them hysteroscopy. Uterine, assessment is very important. If we do it with hysteroscopy in the same sitting, we can manage if there is a flimsy adhesion or any irregular thing that we see. We can treat the cause at the same time. Now, chronic endometritis has been discussed widely, being a cause of thin endometrium, but most of the studies have not found it to be a contributing factor and treatment protocols have not been identified. However, we know that chronic endometritis, why is this that they could not find anything? The definition was different because if the plasma cells, CD138 positive cells are found, we need a histopathology of the endometrium. And then they also found that during the proliferative phase, naturally the CD 138 positive cells were higher in number compared to the luteal phase. So they needed a different definition of chronic endometritis for different phases. So I think the studies were not very regularized, and that's why probably we don't have evidence. But of course, we need to look into this. Now, what do we do when we get a thin endometrium in FET? So there could be two situations. One is that in fresh cycle, the endometrium was good, but in FET, we are not able to get a good endometrium. Or there could be a thin endometrium right at the fresh cycle itself. In the fresh cycle, if it was there, we would follow whatever I was mentioning in the slide before this. But if we come across the endometrial thickness to be thin, even during FET cycles, how do we go about it? So again, we'll take help of the Canadian Fertility and Andrology Society guidelines. Here they've clearly mentioned that below 7 is where we need to counsel the patient about the negative impact on the pregnancy and live birth rates. The history of thin endometrial patients, they have clearly mentioned that there is no sufficient evidence to say that whether natural cycle would be better or hormonal replacement cycle would be better. But all of us know that if we have tried one, then we would move to the other protocol just in case we found it thin. So what interventions are we looking at in FET cycles? The hormonal approach, vascular approach, and a growth factor approach. So hormonal approach is, of course, estradiol dose adjustment. We could increase the duration, the dose of estradiol. We could change the route of administration. So a lot of studies have been done starting from 2006, and they have demonstrated that we can go even up to 82 days giving estradiol without affecting the pregnancy rate. So, you can just keep on extending if you don't find that it is adequate. Of course, it tests our patients and the patients as well. But yeah, they have said that up to 82 days also it works. Some studies have said up to 36 days. In our unit, we go up to 30, 31 days, and then probably enough patients is lost to cancel the cycle. So the dose, we start with 6 milligram per day. We can go up to 12 to 16. The duration can be up to 2 to 3 weeks. However, we need to be aware that there is a risk of venous thromboembolism, cardiovascular disease related risks are higher. And of course, the liver also gets impacted when we move up the dose. So what do? We can move to transdermal, estrogel, because this is the comparison slide wherein we know that the oral estradiol has a first pass metabolism, which is avoided in estrogel. It is metabolized to folliculin, which has impact on the liver, increased risk of thromboembolism, whereas estrogel, because there is the first pass metabolism is avoided, effects on the liver are not there. It maintains a stable serum estradiol level compared to oral estradiol, and reduced risk of thromboembolism because the blood levels are lesser, the serum levels are lesser. Bioavailability is 2 times higher compared to the oral forms. And to just for information, I think all of us know, but one actuation of estrogel would be equivalent to 1 milligram of estradiol valerate. So if we are giving one actuation, that would be equivalent to 1 milligram of estradiol valerate. Also, gastritis, nausea is something we see very commonly with the oral drugs. Estrogel takes care of that as well. So whenever we have to increase the dose, we can move to estrogel so that all these side effects are avoided. We can also, same thing, we change the route of administration. We can go to vaginal route as well. Same formula, it bypasses the first pass metabolism and has lesser side effects, has seen to be very effective because it is associated with first pass uterus effect. So the level in the uterus would be better. However, various doses, we can start with gel also. There is no study which has demonstrated that there is any benefit in terms of live birth rates. Now, coming to the vascular approach, basically we are trying to increase the flow to the endometrium so that whatever estradiol is there in the blood would get, to the target tissue. It is supplied to the target tissue if the vascular supply gets better because of this vasodilator effect of all these drugs. So same thing with sildenafil, pentoxifylline, vitamin E, aspirin. However, various studies have studied various doses starting in the follicular phase, continuing in luteal phase. However, no conclusive evidence again has been proven. So their role has not been proven. However, in our practice, we do use vitamin E in the dose of 1000 milligram per day, 600 in the morning and 400 in the evening. We do add aspirin also in certain patients. Sildenafil we haven't used. Coming to growth factor approach, there is something called GCSF, which people have used. PRP is now, being used by many people in various doses. But again, because of this, the structure of the studies, there is no clear evidence to support routine use of this. So to sum up the evidence regarding interventions, frozen thawed embryo transfer cycle, estradiol adjustment is something which is low to moderate. All others have unclear effect. In fresh embryo transfer cycle, people have tried using GnRH agonist in luteal phase, but again, all of them have unclear effect. So again, we don't know what exactly to do. Coming to regenerative therapies, this was a study which I came across. It is a study conducted in 2023. So these are the studies which they tried to study about autologous PRP. If you look at this whole chart, it is quite busy, but they have used people have used up to 0.5 to 1 milligram of PRP, several times. Also, once some people have put it hysteroscopically with IUI cannula. But the whole thing is, look at the numbers. None of them has even a number of 100. The largest was by Russell in 2022, 85. They have demonstrated an increased live birth rate, but this was a retrospective study compared to the prior cycles. So the quality of evidence that we have is not enough to prove that it, and we don't even have standard doses. So basically, PRP preparation protocols, the dosage criteria, everything varies different across different studies. So in future, we really need to standardize treatment protocols and report the essential outcomes like live birth rates. It has been proposed that it increases the growth factors, peptides, cytokines, and thereby improve the endometrial thickness and receptivity. However, even ESHRE in its good practice recommendations has not advised intrauterine PRP infusions for endometrial proliferation. So we need to establish its effectivity, safety through well-designed studies to have more robust evidence. It has a good biological plausibility, but we don't have enough evidence and we don't really know what standard dose works. Coming to stem cell therapy, we know that stem cells have a high self-renewal capacity. They can differentiate into multiple cell types, and therefore it's a promising frontier where we can use them to restore endometrial function, especially in patients with thin endometrium. And that's why various scientists and researchers have used mesenchymal stem cells as a therapeutic potential in thin endometrium. So mesenchymal cells from bone marrow, from placental tissue has been processed, directly injected. Some people have injected in the uterus, some people have injected in the uterine artery. So a lot of reports are there, but again, there is no standardization. However, it seems to be a promising approach. Mesenchymal stem cells show promise in promoting regeneration and repair. We know that in a scarred uterine lining with thin endometrium. However, further research is required to address limitations, ensure safety, and standardize the therapies. And it could not only increase the pregnancy rate, but those complications which I was mentioning initially, like the placental abnormalities, could also benefit from better endometrium. But again, if we look at the stem cell therapy for thin endometrial studies, look at the numbers. The intervention group 1, 6, 18, 20 maximum, most of them, like, the numbers are so low because we even need to find patients. Once we tell them that we are trying all of this, they might not be ready. Sometimes the diagnosis, the inclusion criteria have to be met. In fact, in Gangaram we are conducting a study, and I would like Dr. Bhavani to elaborate on that study, where what are our inclusion criteria. We have almost done, I think, 2 or 3 cases till now. Hardly any result, unfortunately, but Dr. Bhavani would just tell us in just where we are standing in that study. So people have also come up with tissue bioengineering, and wherein they are using collagen scaffolds and decellularized scaffolds, hydrogel and all to facilitate tissue repair and regeneration. They also enhance the delivery system, survival and functioning of stem cells. People have also come up with something like Avatar, which is a microfluidic system by integrating reproductive tract tissues to peripheral organs through a microfluidic platform. A lot of research is going on, but we still need to be very, we are at the very basic level of research, and we need to do much work on this. So with this, I would like to end my talk with the take-home message that thin endometrium is an infrequent but challenging occurrence. A detailed history evaluation might help us differentiate into constitutional versus pathological thin endometrium, and thus give us confidence to go ahead with transfer at a ET even less than 7 mm. Individualized decision rather than being obsessed with a cutoff would help us better. Asherman syndrome is the most challenging iatrogenic cause, and hence preventive approach while we are doing any intrauterine surgery is very important. Thin endometrium is a rare occurrence. Lack of study protocol has been a hindrance to adequate research and has led to lack of evidence for clinical practice, especially for regenerative therapies. But however, tremendous amount of development is happening in this field. So to raise new questions, new possibilities, to regard old problems from a new angle requires creative imagination, and that marks real advance in science. Thank you so much.
Thank you for such a crisp and comprehensive talk, Dr. Tejashri ma'am. So we
Thank you.
will be taking up some questions.
Bhavani, would you like to tell about our study first?
Yeah, so this study, we are putting umbilical cord derived stem cells into the uterine cavity. We're injecting it hysteroscopically in patients of Asherman syndrome and patients with the refractory thin endometrium without Asherman. So we are taking patients with an endometrial thickness of less than 6 mm and who are awaiting embryo transfer, and where we have tried all interventions possible and nothing has worked. So as of now, we have instilled stem cells in 8 patients, and we are following them up every month and checking for their endometrial thickness and blood flows, and doing a hysteroscopy 3 months after injecting the stem cells. So we have been able to follow 4 patients as of now, where we have done a relook hysteroscopy and found a significant reduction in the Asherman score and a slight improvement in the endometrial thickness as well. And we have done an embryo transfer in, as of now, we have done an embryo transfer in 2 out of these 8 patients, where one is carrying an ongoing pregnancy as of now. So we are still in a very nascent stage of the study. So at this stage, it is difficult to come to a conclusion, but after a few months, maybe I'll be able to tell. Can you please mute yourself? Dr. Aishwarya. Dr. Aishwarya, please support team. Can you mute others?
They have to mute themselves. I can just request them.
Okay. So, yeah, so we are still in the very initial stages of the study, but as of now, 2 patients have undergone an embryo transfer after stem cell injection, and one is carrying an ongoing pregnancy. So we are still awaiting the other results. So there's a question, Dr. Tejashri, there's a question by, the name is not mentioned, but what is the choice of preparation you prefer, estradiol valerate or hemihydrate?
So the hemihydrate, when it had come, they had proposed that this is a more physiological form and more identical to the endogenous form. We had been using valerate for a long time. We shifted to hemihydrate few years back, and I think we found the same result. We were happy using hemihydrate. nothing abnormal. I mean, nothing that we saw could, be a problem. So we have almost shifted to hemihydrate, 70-80% of our cycles. Some patients who can't find the preparations are on Valerate, but mostly now we are using hemihydrate.
And ma'am, what has been your experience with the vaginal route that we recently adopted? Are you still trying it in your patients?
See, few patients, they really, they respond very well to the vaginal route if they are not forming endometrium after a period of 10 to 12 days. We shift to the vaginal route and it works very well. But I feel that, vaginal route is a little difficult for the patients. Also, when we start adding vaginal progesterone, because most of our patients, we use vaginal progesterones as a luteal phase support. And then using, 3 times the vaginal route for estradiol and then twice the progesterone thing becomes a little too much for the patients. But otherwise, if we look at the result, most of the patients do better with the vaginal route when we change from oral if they're not responding to oral. Because I think the first pass uterus metabolism is something which is better in vaginal.
And there's another question by the same doctor. How do you manage CD138 positivity in different phases of the cycle?
So it is a marker of chronic endometritis, and we give doxycycline 100 milligrams twice a day for 14 days in these patients. So that is what we do. We also like to give a probiotic. So that goes for almost a month. So any patient that we find that has a finding of chronic endometritis, we treat with doxy and
Dr. Yukti is
probiotics.
asked, Dr. Yukti wants to know how to go about the non-LF pattern of endometrium with a good thickness. Is there a decrease in the
So
pregnancy rate?
So basically, endometrial thickness is something which is primary for us, but we also have to look at the history of the patient. Again and again, I would like to stress this, that if there is any history of intrauterine surgery or evacuation, and we are looking at a pattern which is not looking normal triple line, we would still like to go for hysteroscopy, even if her endometrium is 7 or 7.5, because her pregnancy rates might be less. Or the second is that sometimes we think that, the endometrium is fairly good and there is no history of any intrauterine surgery, any intervention, then we would go ahead with one transfer. But if she fails in that and the pattern is not looking good to us, then certainly we will go for hysteroscopy.
So according to you, you give more preference to pattern rather than thickness.
Yes, especially if the patient has a history. And even if the endometrial thickness is good, but the triple line appearance is not there, and there is a history of intrauterine intervention, of course, then we would have to look for even flimsy adhesions, which might decrease the clinical pregnancy rates. Especially with the good quality embryos that we have, we don't want to waste those embryos if it's not a good endometrium with a history that she had some surgery or evacuation.
And according to your experience, when do you cancel? Evidence says 8 mm for fresh and 7 for FET. But for you, what is the cutoff for
So
cancellation?
basically, for any patient who would have a thin endometrium in the first cycle, I'm looking at her endometrium for the first time, and I've done everything, and it's not reaching the adequate thickness, despite not having any significant history. I would certainly like to wait, cancel, look for the cause first, whether I can do something more to build up the endometrium rather than hurrying up doing a transfer. So anything, less than 7. And also, if it's a FET cycle, I would like to compare it to the fresh cycle. If she's made a good endometrium in the fresh cycle, then probably we can find more causes, get a better endometrium, because that's a standard endometrium that she was making even in the fresh cycle where supraphysiological estradiol levels. So looking at the context, I think if there is a repeated thin endometrium that I'm seeing right from fresh cycle, even in her FET, maybe change of protocol, uh, you know, and the pattern is triple line, I would still go ahead, do one transfer if I'm not able to find any cause, and it is good triple line persistently, maybe lower than 7. We have done transfers in endometrium of 5.5, 5.8, but of course, somewhere if we are suspicious, then we would also do a hysteroscopy in these patients. If it is not going, beyond 6.5, we would first like to see if there is anything that we can find on the hysteroscopy. And if we find that the hysteroscopy is absolutely fine, a good triple line endometrium, we would go ahead do the transfer. Even, we've got pregnancies at 5.5, Dr. Bhavani, if you remember that
Yes,
patient.
yes, absolutely. And when it comes to tackling a patient with an endometrium, HRT has not worked, then if you go for a stimulated cycle, what do you prefer? Letrozole, gonadotropin, what is then your
If
go-to
we,
in that case?
yeah, so the reason that we mentioned one in the IUI cycle, the comparison, the gonadotropin cycles always had a better endometrium compared to CC and letrozole. So there are cases of PCOS also, which kind of present with thin endometrium despite giving them HRT for a long time. I could not somehow find any studies in this class of patient, but Dr. Bhavani, we come across so many patients, and I'm sure many of the consultants who have joined in today would be facing this, that a case of PCOS, we try to give them all sorts of HRT, but somehow I think the receptors of estradiol are already, occupied by their natural estrogen, and that's why the external estrogen just does not act. And even in HRT cycles, we keep on giving, but the endometrial lining is not formed. In these patients, I would first like to give them a letrozole, see if a natural follicle which is developing helps in making a good endometrium. Otherwise, I would prefer a gonadotropin cycle.
And what is your experience with tamoxifen, ma'am? Have you tried that in your
Very
practice?
less, I think, very less use of tamoxifen. But yeah, that is always there. The option is always there of using a tamoxifen if the patient is not comfortable with gonadotropin. She's already undergone a fresh cycle, and site retrieval. We would like to use tamoxifen if she's not willing to, but we would prefer to have a gonadotropin cycle that always works the best.
Dr. Dhaval Belvi wants to ask, is there any role of growth hormone in thin endometrium?
No, growth hormone, I did not find any, study with using growth hormone, but people have also used HCG injections, even hysteroscopically, intrauterine. So I could not find any study which showed a significant difference. Personally, also, I don't have experience of using growth hormone for thin endometrium.
And she also wants to know, when do you add LMWH in an HRT cycle?
So LMWH and HRT cycle generally, so ecosprin and LMWH have different actions. While ecosprin acts on the arterial blood flows, LMWH does act on the venous blood flow. If we find that we are giving high doses of estradiol, the patient is obese, we want to prevent DVT, that's one indication. Uh, we haven't used it for thin endometrium as such, but yeah, patients who have probably had failure of implantation, one or two cycle. I mean, the definition of RIF, wherein two good blastocysts have not implanted, and probably we want to see a better blood flow of the, we like to add LMWH in such cases. Just for thin endometrium, we've hardly added LMWH to any patients, and I also again could not find any evidence to use LMWH in these patients.
What is your
What do you
opinion?
think, Dr. Bhavani? I mean,
No,
what do you think
LMWH,
about it?
yes, not for thin endometrium. Yes, in
Right.
RIF we can consider, history of
Yes.
RPL we can
And it
consider,
is
but
more to
not
do with
for,
its immunomodulatory role
yes,
in those
yes,
cases rather than anything else. But yeah,
absolutely.
if a obese patient, we are doing a HRT, we are giving it for a prolonged period at a high dose, we can consider LMWH for DVT prevention in these patients.
Yes. And what is your opinion on this very usual practice of giving estrogen in IUI cycles to increase the endometrial thickness?
Uh, see, adding estradiol in after a certain period is still okay, but after the selection of the dominant follicle. But if we start adding estradiol before the dominant follicle is being selected, it will have a counterproductive effect, because LH surge will then not happen and then we'll be struggling. So we are here in IUI cycles, we are using the physiology of stimulating the follicles, making them grow, and the estradiol itself makes the natural estradiol itself makes the endometrium. So if with that high kind of estradiol, if the endometrium is not forming, what will external synthetic estradiol do? Because already the receptors would be full of estrogen. So in a cycle wherein the gonadotropins are given and the natural estradiol levels are high, external thing would hardly work. In fact, it would have a counterproductive effect in preventing the LH surge sometimes.
Yeah, and
So
you've
it's not going
already
to help.
shown us, yeah, and you've shown us that there is good enough evidence that in IUI
Yeah,
cycle, the endometrial thickness is not
not
that important,
yeah, we should not be
not a concern.
using it to cancel the cycle.
Yeah.
Yeah.
Are there any more questions? You all are welcome to ask. I think we're done with the question, ma'am. Thank you so much.
Thank you so much for
It was
joining
an
in despite
excellent
Dr.
lecture.
Abha not being here. And I'm sure Dr. Abha would be trying to join. Next time, I think Dr. Bhavani will be taking a class, and we will soon let you know what the topic would be. Thank you so much for joining in. Good
Yes.
night. Thank you,
Thank you.
Intas team. Thank you for taking this initiative to have the masterclass going on for all of us. Thank you so much.